20-bedded primary care rural nursing home center near Dindikal, completed fellowship courses in diabetology and endocrinologist, convener and honorary secretary of our Club Pulmonary of Dindikal since 2014, won the Best President Award for IMA for Dindikal branch, both in the state and national IMA 2009 and 2010. Welcome, sir. I would like to welcome Dr. Ravi Kannan, consultant diabetologist, Sharak Clinic, Coimbatore. Thank you. Over to the chairperson.
Good morning, all of you. It's a great pleasure to welcome you all to this session. And also, I thank our Kumaravel sir and his team for conducting this excellent conferences, etc. It's taking endocrinology to the root. It has to travel. All GPs, especially specialists, they get really benefited by such conferences. The topics have been so designed, they are so simple, and speakers are so excellent. You can translate it the very next day to your next patient. So, the amount of material this conference is much higher compared to big conferences which take 3 or 4 days. So hats off to Dr. Wilson and his team on consistent conferences. Please give me a big hand of applause. It's an honor to invite me here as a campus engineer. The topic is thyroid nodules. We know the incidence of thyroid nodules is increasing day by day. It's increasing day by day. We have diagnosed more number of thyroid nodules nowadays due to various technologies available. But many people go along with thyroid nodules, they don't do any harm to them and they don't do any harm to the thyroid nodules. The problem comes when you have an incidental and you have you wonder what to do. We got Shida Mahadevan as excellent speaker. Welcome sir to the dais. He's a talks. He's a good teacher. He thinks and talks from his heart, and he will learn new angles to the topic. So he's currently professor head of endocrinology, diabetes and metabolism, Chirag Medical College Institute of Higher Education Research. A lot of things about him take a lot of time. But I know he's a very simple person, straightforward person, a good academician. Welcome, sir. Over to you, sir.
Thank you, sir. Thank you for the kind words and very good morning to all of you. And any amount of thanks will be less to Kumaravel for inviting me every other year for this meeting, which is almost like home coming, second home for me now. Madurai. The topic given to me is approach to a patient with thyroid nodule. And as usual, a tagline like, rationalizing guidelines. I'll give you a bird's eye view of how we approach the nodule and from clinician's simple primary care level or at least a secondary care level and how it is evolving. Before that, few questions. I hope the audience will at least raise their hands or answer in a voice, so that we get an idea. Sir already pointed out, the chairperson sir, that how many of you think in this audience that the thyroid nodules have really increased, or is it due to, as usual, overuse of investigations, which could be radiological investigations, most commonly ultrasound? How many of you think it is really increasing? Scan that's we will see. I will give you, in the next 15 minutes, you will have some clarity, I hope so. Second question is, I deliberately put question 0. No specific idea. If I Madras full 0, all the traffic police has kept a 0 symbol everywhere with a road or a symbol. Traffic easy flow, 0 traffic. So how many of you feel this was, I am from Stanley Medical College, many of you might be from the same 92 batch. So during our surgery, and incidentally, after I read endocrinology, I became more of a thyroidologist. But during my MBBS training in government hospital like Stanley, 90% of thyroid disease are treated by surgeons. I'm sure all of you agree. Graves disease, and this was one of our standard statements made by many of our teachers. Solitary nodule, how many of you feel will be more malignant than multinodule? The statement I'm not the public person. Surgery area. There's no surgeon general practice. Exactly. Another question. This is a standard statements made. You will see whether these are all how correct, etc. How many of you feel that cold nodules are more likely to be malignant than hot nodules? 30%. This is MCQ, MCQ, MD exam. Which is the best initial? The MCQ is more a trick in answering rather than the concept. Concept is very no, and the word. Which is the best initial investigation for a suspected thyroid? இங்க எனக்கு ஒரு 5-6 FNAC காது இருக்குது. அவங்க பின்னாடில இருந்து யாராவது FNAC அதானே? Okay. Almost 30-40% FNAC தான் சொல்றாங்க. We will see again. After 15 minutes you will know whether the answers we can come to some consensus. I won't say always what I see from the literature is correct. So we will try to answer these 4 questions under these headings. How we are approaching in the last decade, things are changing in a significant way and very useful to know some of these concepts. First of all, just because we feel a thyroid nodule, it need not be a nodule. A thyroid nodule is defined radiologically by an ultrasound, where the sonograph picture should be, the thyroid nodule should be different from the surrounding parenchyma. Otherwise, it is not a nodule. Please, this is an important point to note. So, நம்ம ஃபீல் பண்ணுவோம் நிறைய வாட்டி, எஸ்பெஷலி ஹாஷிமோட்டோ ரொட்டீன் ஹைப்போதைராய்ட் பேஷண்ட்லாம் வருவாங்க, ஃபாலோ பண்ணும்போது ஏன்னா ஒரு மாதிரி ஒரு பக்கம் வீங்கின மாதிரி இருக்கும். ஆனால் அல்ட்ராசவுண்டில் பார்த்தீங்கன்னா இட் வில் பி ஹோமோஜினஸ் சேம். தட் மீன்ஸ் தட் இஸ் நோ. Don't blindly put a needle or do anything. So nodule is defined as a discrete, radiologically distinct from the surrounding parenchyma. Number 1. Number 2, many times nodules may be felt nodule mari, but they are not. So it could be as usual. We know patient naane paathen munum bodhu ellarum sonanga physician, as has been pointed out by the audience today. There are ultrasound which are done for various purposes. Sore throat vanda kuda ipo ultrasound la panna arambichatanga. And today there are many reasons for which these scans are also done. So the pickup rate is high. But is it the only reason for why the nodules are increasing or cancers are increasing, etc.? We will see. So the prevalence obviously will vary depending on whether you do an autopsy study or surgical series or in the mari or big or 1000 பேர் இருக்கிற இடத்துல எல்லாரையும் கிளினிக்கலா பால்பேட் பண்ணலாம், அல்ட்ராசவுண்ட் பண்ணலாம். So the percentage of nodule pickup will depend on what modality of test you use, whether clinical or radiological, etc. And thankfully, with iodine deficiency coming down in a big way, frankly, the percentage of goiter has come down in the population. There is no doubt about it. However, certain other conditions, there is a big Pandora's box if I open as to what has happened in the last 3 decades after iodization. The worry is not just nodule or goiter increasing, or the cancers increasing is the most important one, because we are not, just because of nodule, we may not, we have the abdominal obesity increasing in a very big way, but not every time everybody is too bothered about it. We accept that as part of today's, it's the way evolution happens for us. Another thyroid nodule, it's the cancers increasing is very disturbing question. So this is some very important data which are all published in big oncological review journals. I would like to re-emphasize the picture. What they are showing is, it is not the nodules which are clinically palpable, which means usually they say around 2 centimeter nodules will be picked up by a good clinical examination. That itself is increasing. It is not just ultrasound pickup of less than 1 centimeter micronodule or 2 centimeter nodules say dramatically it is increasing. And the most important point, these are all from children, by the way. So all over. Cancer, confirmed papillary cancer rates have also significantly increased. You can see the graph going up here. They are all clinically palpable nodules with more than 2 centimeter and confirmed cancers. Those rates are also increasing. So it is not just, we say that I agree that one side there is a pickup rate that's also high, but the proportion of patients who are having cancers are also pretty high. This is being repeatedly getting documented, and there is, fortunately, in the last 2 decades, a lot of Indian information, especially from Kerala, there is some publication like this. The incidence of thyroid nodule, which are cancerous, are unfortunately increasing. We can go into why it is happening, etc. That will be very futile, but disrupt our chemicals to anything can be hypothesized. So this is, So the papillary cancer of some degree, we have varieties of papillary. It behaves so benignly that we many times consider PAPC as a curable kind of cancer. So, but still, even today it is defined as cancer. So, if you go by papillary cancer incidence, definitely it has increased in the last few decades. So, what are the risk factors we need to know before we say how do we approach? You can't change some of these like gender and age has to increase. So, obviously, with increasing age, iodine deficiency, radiation, the important. Clinically, any radiation has been given in childhood, in the neck area, for some reason, or they have a family history of thyroid cancer, especially the MEN types, or they have an underlying autoimmunity, which is very common today, but significant autoimmune chronic lymphocytic thyroiditis may actually turn into rarely lymphoma or similar conditions. So that also needs to be kept in. So why should we know about these nodules? Why are we worried? The answer. We are worried whether this could be a malignancy. What are all the features we can get clinically or by some simple investigations which are available or the next investigation, whatever. So ultimately we need to know whether this nodule is some fellow who is suspicious who will do something bad to me. So the incidence of malignant nodules can vary, especially in non-surgical series, anywhere from 5 to 6%. So, as we all as clinicians always say in meetings, and we should definitely try to practice the same way, is take a reasonably good history so that dig into the history, whether they have either obstructive symptom, family history. Family history, operation that could be a laryngeal CA for which they would have gone. We need to use our clinical judgment and dig into the history. We do TSH, we do an ultrasound. If we are the question answer on the FNSA count. Yeah, we will see that. We'll see that the initial investigation. So, in the history, we should focus on how did they notice, how fast it is increasing in size, or is it painful, and the multiple other swellings. These are all rare things, but if they are there, they are high risk. We are really high risk, like BMT, total radiation, or lymphoma, or ALL in the younger age. They would have given spine radiation, which will cover the neck, and family history of thyroid cancer. It could be either papillary. When we say family history of thyroid cancer, papillary may be there, but more importantly, medullary and other those MEN kind of symptoms. And there are these rare syndromes which are definitely associated with the increase of thyroid. Because they're extremely rare, we will not go into it. So, when these things are there, the top one, most important, definitely the malignancy possibility is high. Such a nodule should be aggressively, and whatever available tools, you should do investigations in the best possible way. Some history of, change in voice which is persistent for more than 2 weeks. Sore throat more than change in voice. And Mudungar the customer has become like a routine symptom, and they go to some other person and they scan over children. Mudungar is due to sore throat, nodule is different. Very commonly we see every day. And wait for 2 weeks, 3 weeks till you give a course of antibiotic or whatever, and then use it. And our basic surgical teaching, it is hard, fixed, multiple regional nodes, all these are definitely high risk. If these are not there, then our suspicion rates will obviously come down, and depending on how we investigate, that will matter. Okay, I put this specifically to say that it is a common misconception usually to feel that a solitary nodule means it is more risky, multinodular less risky. Multinodular, there will be a particular nodule which will turn into it. These rates are misquoted in some of our papers, so you have to evaluate in the same way, whether it is solitary or multinodular. Many times nuclear scans are done, and a common misbelief is, a belief that the whole nodule will be more malignant. It's the other way around. Malignancy is non-functional usually. So if you happen to do a technetium or radioiodine scan in a malignancy case, it will not take up iodine, so it will be cold. Cold nodule invariably is due to colloid nodule. It is not due to malignancy. So this statement that colloid nodules will be causing, cold nodules are more malignant is actually wrong. Not a correct statement. It will be like saying, if the smoking and cancer association. If you take cancer patients, 100 patients, maybe predominantly there will be smokers. But if you take 100 smokers, the malignancy rate will be pretty low, maybe as equivalent to general population. So the most important message from this is today ultrasound done by a person who is interested in this area, qualified enough to identify thyroid and nodules properly, is the first investigation of choice. Ultrasound is actually taking one step above FNAC. In fact, the FNAC should be guided by the ultrasound picture. So please do we should have regional teams actually. If you are working in this part of Madurai, you should know where to send in Madurai to an ultrasound you can discuss and get the correct information. And based on certain features which I discuss in the next 2 minutes, these ultrasound will give you very good information as to what the nodule will be. Based on that, you should decide further. Do not put these blind needles into one nodule and get some aspirate, invariably bloody, not reportable. This should not be done in today's world. 2024, I am talking like this. 20 years back, this was not the teaching. I am sure all of you know. And these investigations have no role. CT, MRI, nuclear imaging, to know what is the nodule, very rarely this will help. In fact, I can put the other way around. In the corona, chest CT many times there will be a cut. So the other nodule. So incidental pickup can happen. But whether you pick it up by PET scan or MRI or CT scan, the patient has to undergo an ultrasound, do what is called the thyroid scoring by a properly done ultrasound and discuss correctly, then do an FNAC, then decide if necessary an FNAC. FNAC can be avoided in many situations. So this is the classic typical textbook kind of a teaching picture where you know how it is supposed to look like in the cross section of the neck, where trachea and the strap muscles and thyroid are supposed to look same, and based on that you say hyper and hypoechogenic areas, and that is the minimum resolution of ultrasound you should get. இப்போ எல்லாம் ஹை அண்ட் எங்கேயோ போயிட்டு அதனால என்ன தேவையில்லாத இப்போ 3 டெஸ்ட்ல MRI 7 டெஸ்ட்லாம் ஏதோ வருது அந்த மாதிரி you do a higher test, sometimes you will pick up noises, not the information what you want. So based on these features in the ultrasound, these are all the high risk on the right side and that's on the left side. You see on the left side, completely cystic, spongiform appearance and comet tail shadowing. இதெல்லாம் கிளாசிக்கா இருந்துச்சுன்னா no need for reference. It's absolutely benign. இந்த மாதிரி இருந்துச்சுன்னா you have to definitely, especially microcalcification, transverse uvula taller than wider, irregular. இதெல்லாம் சர்ஜரியில சொல்ற மாதிரி தான் இருக்கும், ஆனா அதை கரெக்டா பண்ணணும். And இதுல subjectivity, as you all know, ultrasound is an operator dependent modality, so that person will have a learning curve over a period of a few months or few hundreds of scans. I'm sure he'll pick up, and back and forth with the clinician, surgeon and the ultrasound product. If you discuss, within few months you will get to where is the optimum range at which you can be confident. அது இல்லைன்னா சுத்திட்டே இருப்பாங்க, and unnecessary surgeries etc. will definitely happen. So based on this, you see here, this left side, this is a perilesional halo. இந்த மாதிரி clear cut ஆகலாம், it is benign. Hypoechoic, that's a ominous feature, irregular favors malignancy, and of course vascularity. And I already mentioned, இதுதான் the comet tail appearance versus microcalcification, the difference. These are due to papillary CA. In fact, ultrasound papillary CA pathology la சொன்னோம். Samoma bodies are the most common reason for these microcalcifications. Pure cystic lesions are invariably benign. Other kind we need not confuse too. Invariably means at least 99%. So we have to use a combination of these scores, and that is reported as what is called thyroid imaging reporting and data system. This breast thyroid scoring. Same way in thyroid, which is now and is getting standardized. The reporting way is standardized, but we should develop the habit of how to look at these features correctly. And why am I stressing so much? Because in this simple screening procedure, you will unnecessarily not FNA everything. You can easily avoid surgeries in many benign conditions which are classically ruled out in ultrasound. And you can also easily diagnose other lymph nodes which are not, and posteriorly placed nodules cannot be seen by clinical examination. So blind FNAC is a mistake. And the precise FNA from where you have to take can be easily guided by your ultrasound. And this is how it looks. This is now stuck, at least in the hospital, teaching hospital where I am working. In all radiology rooms, this will be stuck. all the junior radiologists who do also have to report by this American College of Radiology thyroid scoring, and the images இன்னும் கொஞ்ச நாள் ஈஸி சுமரி நம்மளே படிக்கலாம். The correct pictures taken, irregular, cystic, margin, microcalcification, points, count, thyroids too. So it has gone to that level. So based on the thyroids, you decide whether to even FNA or not. So anything in this extreme, like clearly benign, you are not going to do much. Clearly that side, obviously there is a problem. The problem is in the middle floor, the 3 and 4, suspicious and healthy, illama. Same way, that's where FNAC will really help. And there are so many correlating studies like this. And ATA, this is ATA 2015, not much changed after that, where there is almost a 90% association, clear association between the ultrasound characteristics and what is the histological outcome if those thyroid scoring was correctly done in the thyroids 5 kind of situations. Then comes FNAC. We all know we should have a good, properly done, adequate sample is at least 6 groups of well visualized cells and at least 10 well preserved epithelial cells. In probably a single slide is better, and the staining should be good, and usually more than 1 centimeter nodules, because that is easily accessible for FNA is done, and guided FNAC is preferred today. Blind FNAC, unless you are not, if the ultrasound is clearly showing a full solid nodule, you can put blindly. Otherwise, don't do it. You have to take from the solid component of the cystic nodule, both are there. And this is where the problem comes in the same way like thyroids. In FNAC also, clearly benign, clearly malignant. 2 extremes are there. Middle people, 3 and 4. Here also we have Bethesda scoring system, where like thyroids, this is also a scoring system based on these characteristics. I am not going into all this, just to tell you that again we have to talk to the pathologists. Then only you will know why these are all important. And I'm just skipping through some of these just to tell you that a properly done ultrasound, a guided FNAC, discussed properly like a team, like a mini tumor board kind of a discussion will definitely help the patient better than like a small report about it. If that message is taken, I'm sure there are these kind of this. I thought of focusing more on this Bethesda 3, which is the atypical intermediate form, where there are newer things coming up. It will be too much for beginners people if you are not too interested in nodules. But such things are newly discovered in the FNAC, where what was diagnosed as malignancy in the past are now reclassified as benign conditions. And now we have one more thing coming up, which is molecular testing from the aspirate. In US and other places, such big gene sequencing are all there. There are researchers done even in India. One such major study was, I'll skip this. This is from our IPGMR, Calcutta, Dr. Sujay Ghosh group, where they pulled out the FNAC and from the blood also, they just checked the cell-free DNA. It's a concept which is very, in a government setup, it is supposed to be really free, cheap there, less than 100 rupees they can get. Whether he harbors malignancy or not can be checked by a cell-free DNA, which is specific for the thyroid cancer. It was published in our top journal and a lot of cross quotations for this. So, what do I do? The last slide here. I was already mentioning that obviously we have to do good history examination. That is no replacement for all that. Get a good ultrasound by somebody whom you can depend upon, discuss with them, and if they do the FNAC, ask them whether it was adequate. In our teaching hospital, it is easy. Every time there will be a pathology PG also standing, and adequacy is checked with them and there. Then only it goes to the pathology. Otherwise, after one day, they will say, inadequate smear, you can't come back and put a needle in. That's a problem. If you can have such facility, you should send to such places to get the correct answer. And if in spite of all this, if you still, they are not too sure, it looks like this. Many times I'm telling you, this I have told in some of our bigger forums also, where the pathologists, if you talk with them, they will give you the inner feeling, what they felt when they saw the slide. That they won't put it in writing. நீங்க கிளினிக்கலா என்ன பாக்குறீங்க, எனக்கு ஆனா இந்த இடத்துல கொஞ்சம் அப்படி தெரியுது, நீங்க இப்படி சொன்னீங்கன்னா மேபி ஐ வில் புட் இட் ஐ வில் கிளாஸிஃபை as 4. These and all will, இது வந்து நம்ம பேஷண்ட் பார்க்குற மாதிரி தான். சிக் பேஷண்ட் பார்த்தா இது கொஞ்சம் நல்லா இல்லை, இந்த பேஷண்ட் கொஞ்சம் அப்படியே பார்த்தேன் ஹைப்போடென்ஷன் அதிகமாக தான் இருக்கு. You have that gut feeling, no? That feeling a pathologist has when they see the slide, which many times it's not getting translated in words then. So talk to them. If you talk to them, you will get a correct conclusion. So what was the answers to the first few questions? So how many of us now, after all this discussion, think that it is only due to scans? It is no way, sir. The rising incidence of nodules and cancers is actually real. It is not. You are picking up because our technology is advancing also. That is our problem. Then, is solitary and more malignant than multinodular? The answer is no. Both are to be investigated same way. In fact, multinodular is more difficult to evaluate because one will overlap the other. The ultrasound picture will confuse the Rationalizing. You won't know where to put the needle cover. Posterior part will be difficult. So all the more multinodular is more challenging. So if you suppose, in spite of all these advancements in the understanding, till people do nuclear scan, that's cold nuclear. Actually, it's again a misconception. Unless you prove it by FNSC, this cold and hot and all has no meaning in malignancy workup for a nodule. One exception is there. That's the TSH one. If the TSH is suppressed, it means the gland is overworking. All of us know. There, the technetium scan or a nuclear scan will be the first investigation, not ultrasound. That's one exception. If the TSH is suppressed in the patient, do nuclear scan first. And in the nuclear scan, suppose the nodule is clearly hot, then the malignancy rate is almost less than 1%. There is no question of malignancy. It's only a hot one. In the exception, and what is the best investigation today? Initial is ultrasound. And don't go for needle first. Then sonography should guide your needle. And I put it in inverted commas just to remind ourselves that the ultrasound now operator dependent, who is doing discussion, it's not just ultrasound from anywhere and a printed report. Thank you very much for your attention.
Great talk as usual. We have made very points very clear, and as again towards the team effect. Just in all better medicine, team effect comes in big way. Work as a team. One question I'll for a lot of time. Anybody?
I would like our chairperson, Dr. J.C. Shaker, to felicitate our next speaker.